As many of you know, if you've been here before, this is one of the true highlights of the conference. We enlist 4 outstanding people to get a piece of a topic that is near and dear to our hearts. And yes, thank you. And today we have a debate, the resolution of which is resolved that increased access to virtual care will improve the quality of care. And I'm supposed to ask you or to say why this topic is relevant. I have no idea why virtual care would be relevant lately, because I've been in a coma for 3 years and I just woke up 3 days ago, but apparently it's a thing. But seriously, a debate about virtual care is appointment theater. The only issue is, should that be a live visit to the theater or should you watch it on Netflix? Yes, folks, a lot has indeed changed. It used to be an insult if one of your colleagues said you're just phoning it in. Now it's still an insult because you weren't using Zoom for your consultation. And in the spirit of virtual care, Quality Forum has installed 50 cameras around the room, virtually recording signs and symptoms. And we have recorded already 7 potentially malignant tumors. But put away your mirrors. By that we mean out-of-province spies, and you know who you are. Is virtual care even remotely better? Are patients more likely to disclose how much they really drank during the pandemic if it's a strictly in-camera session? Or is the virtual experience missing a dimension? Can it ever replace the tactile pleasure of holding a 20-year-old Reader's Digest in your hand in a room full of people coughing and wheezing while you wait for your 2-hour late in-person appointment? This is the question for today. You can't hear? Gee, all my good lines have disappeared into the ether. Can you hear now?
What about the mic?
Well, this mic isn't supposed to be working. So is that better? No? Yes? No? Okay. Well, anyway, I said I had some fantastic jokes. I'll tell them to you privately later. Should your prostate exam be analog or digital? And if it's digital, isn't it really analog? I'm confused. And I have 4 debaters up here who will resolve the problem for us. So the time to get on with the program is right now, as the clock is tick-tocking away. Fortunately, you're about to hear from 4 amazing debaters who are going to illuminate this resolution for us. So you've heard the motion, and the debaters are as follows. On the for side, arguing that virtual care will indeed make quality care better the more their access to it, we have Dana Hubler. Dana, who is Virtual Doctor of the Day, First Nations Health Authority. Dana has a fan club, and I expect some rigged voting. She's the co-lead real-time virtual support. She's medical director, rural continuing professional development at UBC, and physician advisor, physician quality improvement for Island Health. So she's not bored, so we're even more grateful that she was able to participate in this debate. And to her left and her partner is Holly Blanchette, who modestly, yes, please, a big hand, so give it up for Holly. Holly modestly describes herself as a community member for the village of Valemont, but on our preparatory calls, she's also a counselor. She plays many other roles in the community, and she's essentially the gorilla glue that holds Valemont together. So welcome, Holly. And voting against, or arguing against the motion, we have Jason Leach. If you were here this morning, you know who he is. He's a Scot. He's got a big role in the NHS, and he's a spontaneous debater. And his partner is Jennifer Beveridge. She is the chair of the Health Authority Medical Advisory Committee for Vancouver Coastal, regional director and nurse practitioner, Vancouver Coastal Health, and a family nurse practitioner. So please give it up for Jennifer. All right. Now, we do issue a disclaimer. The disclaimer is that people were assigned their roles in this debate. They do not necessarily believe everything that they're about to say, but they might, they just might, and one of your jobs is to figure out who's lying the most persuasively by the end of it. So with that, we will begin, but first we calibrate the audience. This is a debate, and because we need to have winners and losers in our society, we need to have a final tally at the end of all of it. So we do this by taking a pre and a post poll. Now, the winners of the debate will be the ones who persuaded more to change their minds rather than the initial predisposition. But we want to know your initial position on this. So, first of all, by clapping and applauding, please applaud if you are in favor of the motion, that is, that you believe that greater access to virtual care will improve the quality of care. Applause, please. And yet you showed up in person at a super spreader event. So isn't that interesting? Who among you is against the proposition, agrees with the opponents that it won't?
Well, that's good. We won the point.
Well, we have an overwhelmingly supportive audience for the resolution so far, but that will make it harder for them to persuade new people. So the math, figure it out, folks. The debaters will do in 2 rounds. We will start with 2.5 minutes each, and the time will be counted down on that clock if it's going to be working, so you can see it as you're talking. And I'll give you a signal if you're going over. So 2.5, 2.5, first 1, 2, 1, 2. Then we will have an 18-minute Q&A session where I will probe our brilliant debaters to flesh out their positions and catch them out in logical errors and basically humiliate them. No, it's actually the most illuminating part where people can talk truth. And then we will come back for concluding 1-minute rebuttals, and then we will do a final vote, and we'll be done. So without further ado, who is to begin with you? Ollie, take it away for 2.5.
Thank you. Hello, everyone. I'm honored to be here, and I'd like to thank the organizers for inviting me of an hour of nausea, anxiety, and possible fainting spells. So if you're in the front row, watch out. Virtual care will go a long way to reduce the barriers that many rural patients face when accessing care. For patients without internet access, health clinics can set up an account and then assist them with a virtual care coordinator to access specialist appointments in other communities. A surgeon has been utilizing virtual care to consult with his patients before surgery, and they both found that this was really appreciative of the connectedness they felt. Let's use an example from the rural lens. Brenda has a child that needs to see a specialist in Vancouver, and she lives in Belmont, which is 7.5 hours away. So she takes Monday off of work to drive Edward to Vancouver. They need gas, food, and lodging for Monday. Tuesday, they see the specialist, hopefully at 9 a.m. They head for home, so they need gas and food, and Brenda must take off Tuesday from work. That 15-minute appointment cost her $320 in lost wages, $150 in hotel, $200 to $500 in gas at the moment, and $150 in food. So $820 is gone, and Edward missed 2 days of school. And if Brenda has other children at home, then arrangements in childcare had to be made, or her husband had to take more time off work, which means more money's gone. If the appointment was in the early morning, and if not, they stay another day, and the cost is over $1,500. And what about if that appointment is in the wintertime? Patients are needlessly being put at risk. This risk could be eliminated through virtual care. And additionally, not everyone has access to a reliable vehicle or a ride to an out-of-town appointment. With virtual care, it costs nothing. She meets online with a specialist 15 minutes out of her day, and the risk to her and Edward is nil. Some will argue that doctors need to do a detailed exam in person, but how many of us have actually really ever had a detailed exam? The local doctors can do an exam if required on behalf of the specialist. When there will be a value in having that in-person appointment, then the travel risk makes sense. It seems that we're downloading all of the costs and risks to our patients. Carbon footprinting is something we all need to be aware of as we travel the highways when we don't have to. The Canadian Medical Association surveyed last June suggested 47% of Canadians use virtual care, such as calls, emails, texts, or videos during the pandemic. Of these, 91% were very satisfied with the experience. Myself included, I was 100% satisfied with my appointment. Virtual care is a win-win for the patients, the physicians, and utterly for our community. Thank you.
Well, thank you for that. And although you create some good examples, I'm going to argue that you're wrong and remain in my stance against the use of virtual care. But first of all, has anybody noticed who my partner is? Mic drop. The Bonnie Henry of Scotland, we're good. And now I'm going to pull at your heartstrings a bit. Let's stop for a minute and think about how good we all felt when restrictions were lifted and we could once again have connections and interactions with each other. I want each of you to reflect on the first hug you received when we were able to start being closer than 6 feet apart. Think about how it felt. Think about how the joy and comfort you experienced. There's an abundance of research right now regarding happiness and loneliness. Human connection is the foundation to addressing loneliness. We all need and desire human connection. Evidence over the past 3 decades indicates that there's a strong correlation between positive relationships and connection between a healthcare provider and the impacts on patient outcomes, including lowering blood pressure, continuity of care, or decreasing emergency room visits. Patients need connection. They need longitudinal relationships for continuity of care with their healthcare providers. I argue that this cannot be done by the transactional care that's provided in the virtual realm, which is most often based on episodic care. If we continue to grow the use of virtual care, we will lose the human aspects of healthcare. Robots may as well be providing the care. We can ask Mark Zuckerberg to run our system and have it all automated. And soon our world will look like the Jetsons. I think I dated myself there. Our opponents have and will argue that virtual care increases access to services. I ask each of you to consider the following questions. Doesn't each person have the right to have access to quality care in person by a human? Just because you live in a non-urban center, why should you be punished by only receiving care via Zoom? How many people have tried to schedule a medical appointment in the last year and only been provided the option to have virtual care? Now imagine that you are someone who doesn't have access to technology or understands the technology or cannot afford it. What happens then? A recent study looked at the socio-demographic differences in patient experience with virtual care during COVID-19. Conclusions of the study suggest that newcomers, people living with lower incomes, and those reporting poor or fair health have a stronger preference and requirement for in-person primary care. We have not educated the public on how to use virtual care services and what to expect with virtual care and what is actually doable. COVID thrust us into virtual care without education and feasibility analysis that is needed. Virtual care has limitations on access to health information and major privacy concerns. The list of cons can go on, including what would happen during a Zoom visit if your provider stood up and they were in their underwear. According to a recent systematic review regarding virtual care, providers have cited maneuvering technology and increasing difficulties building rapport as challenges to virtual care. Similarly, patient surveys have revealed challenges such as difficulty establishing a provider-patient relationship, privacy concerns, and perceptions of feeling neglected during virtual visits. Therefore, based on my brilliant statements above, I argue against virtual care.
Thank you. Good job.
Well, dear elders, colleagues, friends, and my awesome daughter Maren and the audience, I am honored to be here arguing in favor of this motion because it is so clear to me every day in my work that increasing access to virtual care is improving quality. Given the rather unenviable position our esteemed opponents have arguing against equity and innovation, I was heartened to see that Christina and the council had the kindness to at least give your losing argument the charm of a Scottish brogue. Despite the current and emerging evidence regarding the benefits of virtual care, there remain a few arguments against virtual care based on misunderstandings. So please let me share some stories to clear those up. Imagine a man in a remote community in BC. He's not seen a physician for 30 years because through stories and family experiences, he's never known anyone to come out of a hospital unharmed. He's been living with chronic pain and was told of a new service through which he could be seen from home. Via his computer, a doctor takes a careful history, examines him, and suspects a serious autoimmune disorder. Within a few hours, he's having a virtual consultation with the family physician and the specialist, all in different parts of the province. The rheumatologist does an elegant virtual physical exam, orders further investigations, arranges follow-up. The diagnosis is confirmed, treatment is started, and that treatment reduces pain, improves function, stops the progression of the disease, and starts to build hope that healthcare can be kind and safe and accessible and effective and efficient. Imagine a rural physician or remote nurse having instant video support from an emergency specialist or an obstetrician in their small healthcare center during challenging cases, having an extra set of eyes and ears virtually guiding them through an intubation or a difficult delivery. Imagine as a physician having a patient tell you, "Dr. Dana, I just called because I wanted to say thank you. We've never met in person, but I wanted to let you know that our work together over the last few months has saved my life." Yes, it would be ideal if every citizen in every territory of BC had quick access to a local and robust healthcare team who offered highly effective, respectful, relational, and culturally safe care, and that appropriate diagnostics and specialty care were just a stone's throw from their community. The current reality is that many of our citizens, especially those living in rural and remote communities, and those facing physical and systemic barriers to receiving safe and effective health care, require virtual care to bridge the massive equity gaps that exist. Increasing access to relational, high-quality virtual care that is team-based and embedded in our healthcare system is the social justice innovation we've all been waiting for. Thank you.
You know you're in trouble when you have to bring family members to clap for you. So let's go back to the actual sentence in the motion. This motion doesn't say, should virtual care be available or should it not be available, which is what the argument is you've heard. So I think virtual care should be available. That's fine, I agree with them. The motion is, does virtual care improve quality? That's the motion. Not whether it should be available, does it make it better? And the answer is a resounding no. It does not make it better. It makes it evidentially worse. So how many of you know what matters to me is? We're big on that here, aren't we? There's badges outside. What matters to you? You're going to ask the public, you're going to ask the patients, you're going to ask your staff what matters to them. Here's then what we're going to do. We're going to design a system you can't access, you can't use, that doesn't work with this nirvana rural guy who's in his hut somewhere in rural British Columbia with what, fibre-based internet? I mean, is that... In Scotland, he has no access at all. He has a computer, but it's not connected to anything. So what would be the point? So this is not person-centred. This is system-centred. This is all about what we think is best for the people of British Columbia or the people of Scotland. This is not what patients and families actually want if you actually ask them, because here's the thing. They want to see people. If you ask my 81-year-old father, Dad, what we're going to do is we're going to get your doctor to talk to you from the sofa on your iPad. He'd say, I couldn't tell you what he'd actually say, but it wouldn't be polite. So argument number one is it's not person-centred, it's system-centred. Argument number two is it excludes whole swathes of the population. It doesn't exclude us. We're middle class. We have computers. We have fibre access broadband. We can even sign into the Hyatt Regency broadband. The vast majority of people who you know can't do that. That is not available to them. 78% of people in Scotland go online, 22% don't. 90% of people have access, 1 in 10 do not have internet access. So if your solution is internet access for healthcare to cure your cancer, we can't do it for 1 in 10. So we're just going to let them wither on the vine. And only 54% look up health information. So argument number two is it excludes whole populations. Then when it gets really hard, we're going to exclude the seldom heard groups. So no matter how you divide this data, as Jen said, if you divide it by ethnicity, if you divide it by age, if you divide it by income, if you divide it into special groups. So in Scotland, we have a gypsy traveller community, one of our seldom heard groups, no digital access whatsoever. So what, we're going to build hospitals just for the gypsy travellers? And everybody else is going to be in the room with imaginary fibre optic broadband. And my fourth and final argument is it actually hurts. It's not just ethereal, it's not a choice, it actually hurts you. A coroner in Manchester says that in the last year, 5 people have died early because they had a virtual consultation and didn't see somebody face to face. So it's real, it actually matters, and people die because of virtual care.
Well, we seem to have the territory staked out, and I have not yet seen consensus among the 4, not that we're supposed to. So, proponents, You heard a fairly stiff couple of challenges from these two, bad-mouthing virtual care, both conceptually and empirically, which leaves very little room for virtue unless you can make the case again. So what do you say to their charges that this is just, a second-rate option? Sure, it should be available, but it's really not what we would want, and in a perfect world, we would get rid of it.
Well, I think, first of all, if your dad is, sitting at home in Ireland and wants to see a doctor, I think we need to get him one, right?
He's clearly got lost.
I think that it's important to remember that not everybody has a car that can get to an appointment. Not everybody can ask somebody to help them get to an appointment. So I think having this there for them to be able to utilize instead of sitting at home and not seeing a doctor is a good thing to have.
Anything else on that?
Yeah, I would start by saying go Ukraine. And then I would add,
Okay, the gloves are off.
the digital divide is real, and we need to bridge that gap. But the in-person divide is real too. And so the number of people that can't access care because of geography, because of lack of safety, psychological and cultural, the lack of physical and mental wellness to be able to access a system that's built for providers. It's not built for patients, the current system. So yes, the digital divide is real, but the in-person divide is real, and it was there long before COVID, and we're now just making the invisible visible for the first time.
I completely agree the in-person divide is, but that's not what you're being asked to decide. You're not being asked to decide if virtual care should exist for the person who doesn't have a car, who has mysterious, expensive MacBooks and fiber optic broadband, but doesn't have a car or doesn't have somebody who could take them, but they have this mysterious digital solution in a back study where they can suddenly access. You're not being asked if that should be available to him or her. Okay, I can argue that should be available. Is their care better or worse than if they can go to the hospital and see the specialist? It's worse. The virtual care is worse. It should be available, but it is not as good as face-to-face care.
Well, so let me ask you about that, because I'll give you my experience.
The plural of anecdote is not evidence.
Well, I'm not. So you're making the case that it's invariably worse. So I'm a pretty healthy guy. I see a physician every 10 years. But I've never once seen one where I needed to be there, and it was a pain in the ass. I didn't live in a busy city.
Until you need to.
Well, just a minute. But you're making the case that you guys were making was, this is just worse, full stop. You say, yeah, you should have it. But actually, those who argue about the patient experience say it's the whole experience. It's the convenience. It's the how long do I have to wait in there? How necessary was this? And it seems to me that you're saying there is nothing good about virtual
That's
care.
not what I said at all. You're clearly not listening. So my position is that there will be times in elderly people like you where
Fair enough.
Where virtual care might help, because you would struggle to get up off your seat. You might struggle to get out of the house. And I'm comfortable in you having some virtual care. And sometimes that will be appropriate for you. The motion is virtual care improving or decreasing the quality of our healthcare? It is decreasing. In the round, it is decreasing the quality of our health and social care system. There are times, if you've had your endoscopy, when you could get your review done virtually. I completely agree. We are not anti-virtual care. We're suggesting that virtual care is not improving the quality.
I agree.
For some. So some people, that's not going to work. But for some people, it's going to be fabulous.
She agrees with us.
But what happened to home visits? So your argument saying that, well, they don't have a car and maybe they can't get. Well, what happened to providers coming to patients? What happened to home visits? Are we getting to a point where we're so lazy that all we're going to all do is just sit behind our doors all day long and sit on a couch?
That doesn't sound so bad.
Comfortable.
That sounds good.
I would say COVID happened and the in plain sight report happened. That's what happened, and we have to do things differently. We know from the First Nations Health Authority who provide virtual care to Indigenous people all around the province, 93% of them are satisfied with their services and feel they've had culturally safe, high-quality care that was accessible. When we look at pre-COVID in-person visits across the board, people were satisfied in that way 55% of the time or less. It is increasing access, it is increasing quality, it is increasing cultural safety. 16% of people say that they would not have received care at all, they would have not sought care at all during COVID if it hadn't been for virtual care.
So let's be clear, all of the surveys done on virtual care are people who can access it. You ask the people who managed to access virtual care, did virtual care work? Hey, guess what? Yes, it worked for me. What about the 10 million in the UK who have no access to virtual care? Nobody asked them, how was virtual care for you? I have no idea what you're even talking about because I cannot get into it. And just as we're speaking, Scotland have scored.
And I would also say...
You could then access your clinic and call your virtual care coordinator and have them hook you up with some help there. That would be great, right?
I didn't hear.
That was hard to hear.
Oh, okay, sorry. So every clinic and hospital and healthcare facility will have a virtual care coordinator who can reach out and do outreach work and bring the patients in to the doctors.
To make the care better.
Yeah. So they're going to have a better quality of care because they're going to get care.
Where are you going to find those people? Have you seen the healthcare crisis we're in and the bodies? We can't even staff a general medicine unit, let alone creating a whole new profession of virtual care coordinators.
Well, but there's positions that are being filled now because we know that they need to have this because of COVID. Right?
Can we talk about quality? So we know that history taking in clinical practice provides sufficient information for a diagnosis of about 75% of patients before physical exam or any tests. So if you have a patient who feels safe and comfortable and you can observe them in their own setting, you're going to get a lot of information for a lot of, not all presentations, but the vast majority. We know that physicians make diagnoses from history alone in 70 to 90% of the cases. So we are improving quality, and it is a fallacy that it's worse. That's something we want to believe, that we have to be in person. There are times where that has to happen, but the majority of time, we are actually providing similar or higher quality care.
Well, it's a miracle. It's an absolute miracle. Because if you turn up today at an in-person general practice, if you turn up today at a primary care physician in Canada or Europe, you have a 50-50 chance of getting the healthcare you need. 50-50 chance. All of the research says it is entirely random whether you'll get the right drug and the right diagnosis. And yet if we move it virtually, it goes to 80 to 90%. That's absolutely remarkable. Let's do everything virtually. It's clearly magic. It's not magic. We can't get the diagnoses right when we see the patient. If we only see them virtually, a reliance on health literacy, on their ability to tell us those answers, and our ability, our tiny minds, to interpret that into a diagnosis and a treatment plan is fiction. It's absolute fiction.
So let me pursue one angle on this with the negative side. So there is literature.
Whoa.
The negative side of the debate. Jeez, Jason, relax, man. I'm sorry Scotland's losing. Actually, I'm not, but whatever. So
it's 2-1 with 5 minutes to go.
A serious question about telepsychiatry, because there is a substantial literature that suggests it's actually better quality. That is, the clients, the patients, feel safer, they feel more in control, and they like being on the end of a virtual conversation instead of being on the proverbial or literal couch in the psychiatrist's office. So do you see any circumstances where actually not being present physically for the consultation might actually be better from the patient's perspective?
Well, we never said that we were completely against it, that there's times and a place for it, and it's about finding the balance.
Well, yes.
But saying that it actually increases quality care?
Well, they would say yes. I mean, I'm just citing the literature.
But your motion doesn't allow nuance. You didn't allow nuance in the argument, and now you're adding nuance in because you know that side is losing.
I'm a nuanced person.
You can't make up a new motion in the middle of the debate because you think that might make it fairer.
No, I'm just
The
saying.
motion doesn't say brackets except psychiatry.
Well, my job is to seek truth, Jason, so I'm just trying to
if
elevate
your
the tone.
question, irrespective of the debate, is are there some minor times when virtual consultation might make victims of something feel more secure, or there might be a way to build a hierarchical relationship, a patriarchy, a matriarchy over time? Of course. Bring it on.
All right.
But you're excluding 1 in 10 of the population. So you should work out what you're going to do with that 1 in 10 who can't take your option of telepsychiatry.
And I would just argue that it's 1 in 10 or more people who were excluded from the current healthcare system that required people to travel around the healthcare provider's schedule, around the healthcare provider's.
And your solution, your solution in genius equity sense is to replace one excluded group with a different excluded group. Hey! So we're going to take these people and we're going to put them over here. Now there's a whole lot of other people who can't come. Here's an idea. Let's make it better for everybody. And virtual care is not improving the quality of care.
So we're not arguing against taking away in person. We're arguing building capacity and increasing access by creating another pathway.
Terrific. I'll come back in 10 years once you've achieved that, see how it's gone, and I might argue the other way. Right now, virtual care is not improving the quality of care. If Nirvana comes, if you can get the fibre broadband to the hut in rural Shetland, then I might change my mind. Right now, you're excluding swathes of the population.
So would I invite you to ask the Indigenous people of BC who have accessed the First Nations Health Authority virtual Doctor of the Day program for the last 2 years, and 93% of them say it's improved access, it's improved quality. This is not the Jetsons.
Is that not because we haven't been able to bring care to people that need it? Is that because they weren't receiving care? So how do we look at how we actually get people care in person the way they deserve it, anywhere that they live? If you want to see somebody in person, you should be able to see somebody in person.
That is the ideal, but I see that we're a long ways off from that. And I think that there's also people that live right beside a primary care clinic and don't feel safe to access care there that now do because they have another pathway.
I would argue that the people that are not feeling safe to access care of a next door are those that are not going to feel safe also being on the phone. That we have to address why our healthcare system is not safe in the first place, no matter if it's virtual or in person.
Here.
Okay. So I'm going to bring this back and forth to a close in a couple of minutes, but I want to ask each of you, each team, first the team to my left, what, if anything, in what you've heard from your opponents today struck you as, at the very least, reasonable and possibly even persuasive? What's the best thing they said in their debate?
That's a hard one. I think the best thing they said in their debate is trying to find ways to increase access to care. Just that. Stop there. Full stop.
That's it? A short list of praise. Generous, though I can see your impulses are extremely generous. So what did you find in what your opponent said that you thought gave you pause, made you think, maybe they got something there?
I mean, I think I heard an appreciation for relationship, and I think they just need to look at the evidence for how relational virtual care can be.
Interesting. So usually in these debates, we do have a slightly more common ground, but this is good because the debate's supposed to be divisive and leave people who are friends going away as enemies, and I think we've made an excellent start on that today. But I will just ask one further question of the no to the resolution side, which is, do you think there is a way, if you could optimally configure virtual care, ballpark figure, that's a tough question. I mean, I'm not going to hold you to it, but what percentage of care do you think would be about right, all things considered, that if we did that virtually and the rest live would be a good mix for the system?
I actually don't know. I think if we genuinely had universal access, remember, in my country, everybody is signed up with a general practitioner, every single person. There's not a person in our country who doesn't have access to a general practitioner. And it's not universal, wonderful access. You can't all get an appointment tomorrow. Most people can get an appointment this week if they're registered with the correct individual. I think there are times when that could be done on the phone to me to organise a repeat prescription or to get a blood result. But I think that in combination in the round is a reasonable way of doing things. The suggestion that we've got Gucci healthcare over here, and this is the really good healthcare, and we're going to give this group of people over here who we can't get Gucci healthcare to because we've just written that off. We're going to give them Walmart healthcare over here, and that somehow, I don't know what the percentages are, maybe 20% virtual, maybe.
Good. And last to you, which is, do you see any risk that this could be in a let's face it, imperfect world, but a better world? Do you see any dangers that it would be overused?
No. Anybody who has access is better for it, right? And the resolution, which you keep pointing out, says, will it improve the quality of care? Right now, we have people that aren't getting any care. So if virtual is there, it's going to improve it because they're getting it.
There you go. Terrific. Well, thank you for that back and forth session. It was very stimulating. And now we are to the final rebuttals. You each have 1 minute. Again, we'll go in the same order.
I get 2 minutes, though, right?
You get 2?
Yeah, I get 2 minutes.
Really?
Oh, yeah.
You're bargaining for 2? You get 1 minute.
All right.
But thank you. I'll meet you in the middle. You get 1.
Okay.
Okay. Over to the affirmative.
Why? Okay. So the resolution is increasing access to virtual care will improve quality of care. What's the meaning of quality? Quality is the totality of features and characteristics of a product or service that bear on its ability to satisfy given needs. As a patient, I want to access a doctor for wherever I am. Anyone with mobility issues can't always hop in a car and drive to the clinic or have someone drive them. A senior may not be able to have their license anymore. They can't drive. And a single parent may not be able to take time off work. So let's talk about a three-way. Okay.
You just ate 5 seconds.
The patient, the family doctor, and the specialist all meeting online together. Most answers will be immediate, no referrals, no wait lists, no travel, and no risks. Rural and remote physicians and patients have been accessing RTVS, real-time virtual services, with great success since 2020. When I look out at all of you, I see pioneers, risk-takers, and visionaries. Let's be innovative for all of our patients and physicians and work with them to have a better connection.
Great. Thank you.
Thank you. So while telemedicine obviously has some growth, some rapid growth because of the COVID-19 pandemic, we'll obviously see more over the next decade. And as my counterpart said, there's some benefits. However, no one can argue that virtual care still clearly possesses some technical and practical problems for both patients and healthcare providers. We didn't even start to touch on security of personal health data and transmission electronically. We need to preserve the human connection in healthcare. Virtual care does the opposite. We need to advocate and insist that every individual across this province, from remote areas of northern BC, urban areas like Vancouver, to rural area on Vancouver Island, have access to in-person care provided by a human healthcare worker. Health systems funding needs to focus on how we get the care to patients, not trying to find workaround systems that are cheaper, like Zoom. We are at the Quality Conference. Each of you here is here because you believe in quality care. A key point of quality care is access to care. Access to in-person care. Virtual visits impact abilities for providers and patients to build the connections that we've spoken about earlier. Therefore, virtual care is not increasing quality care and definitely not improving patient outcomes.
Thank you.
So virtual care, when thoughtfully embedded within our healthcare system, only improves quality by creating additional pathways to safe and respectful care, thus increasing access to appropriate and effective healthcare services for all, including those members of our communities for whom the current pathways simply don't work. Integrated virtual care increases efficiency by allowing care to be delivered as close to home as possible. Virtual care has created new levels of peer-to-peer support, allowing our patients to receive high-quality specialty care alongside their own local healthcare provider in real time through collaborative consultations and support. Integrated virtual care is a social justice innovation that works toward narrowing equity gaps and saving our planet by truly putting patient choice and autonomy, as well as carbon reductions, at the center of healthcare. Like any healthcare innovation, virtual care in a silo is not perfect, but when mindfully integrated, it can help close gaps and drive forward the change we all so desperately need and want. Thank you.
So I don't recognise the arguments from the other side because they don't refer to the motion you're being asked to consider. It doesn't say thoughtfully included. It doesn't say integrated seamlessly. It doesn't say mindful virtual. If that were included, you might actually have an argument to say that virtual care is as good when you see it in the round as part of this utopian healthcare system that they seem to have here in British Columbia, that clearly we don't have in Scotland, where people are excluded. 35% of those with a disability find it harder to access digitally than those of us without a disability. So we're just going to design a system, because we've got poorer workforce, poorer resourcing, and poorer access, we're going to invent a new alternative reality, and we're going to call that virtual care, and we're going to replicate all the challenges we have in face-to-face care, and we're going to make it accessible to the wealthy and the middle class, and they'll answer our surveys and say it's wonderful. But remember, all of the people who can't access one version are almost certainly not going to access the other. And just as you were speaking, Ukraine scored, and it's 3-1.
Well, thank all of you for a very spirited debate. I think we heard pretty persuasive arguments on both sides. I found myself being torn between, God, this is a nightmare. What are we getting ourselves into? And on behalf of the elderly, Jason, confess that, the prospect of hauling my aging body out of my recently renovated and furnitureless condo to go to the doctor, personally, it's probably be a pleasure, just because it's so forlorn.
For company.
It's so forlorn.
Just for
Because
company.
you're lonely.
On the other hand, being a technological progressive that I am, having acquired my first cell phone 6 years ago, I found myself very much persuaded by the argument that we all have to adapt, overcome our prejudices against innovation, use the COVID pandemic as an opportunity to experience the expansion of a system that will be imperfect. So, to me, I'm glad I don't have to vote, but you do. So, I've got to get this right. For those of you who originally sided with the affirmative, that is, you thought that access to virtual care would improve quality of care, please clap if you've changed your mind to the other side. All right, minds have changed. Now, the rest of you, those of you who were initially inclined to think it was not going to improve the quality of care, how many of you have changed your minds towards a more positive view? Well, I'm afraid it's a fairly conclusive vote. The nays have won the debate. I should say that in future years you may have to do some very fancy statistical adjustments, since when you start off with the room in your palm of your hand, you don't have to lose very many to lose the debate. But it was a wonderful debate. Enjoyed the contributions. I learned a lot. I hope you did. And thank you all again. Please give a round of applause for our core team.